Good morning or afternoon, depending on what time zone that you're in. My name is Beth Green, and I serve as the State Quality Manager with Alliant Health Solutions, Quinn QIO. And on behalf of ADPH, in collaboration with the Alabama Nursing Home Association and the UAB Long-Term Care Strike Team and Alliant Health Solutions, Quinn QIO, we thank you so much for being with us today for our Alabama Infection Prevention COVID-19 office hours. Before I get started reviewing today's agenda, I would just like to do a quick round robin with the Alabama Nursing Home Association and ADPH. If I'm not sure if Melanie's on the call, just to see if you have anything to share with the group today before we get started formally. So, Leanne, I'll start with you.
No, I do not have anything to share today. Thank you for asking.
Thank you, Leanne. And so, as usual, Wade and I will keep a check on the Q&A and chat. We, as always, encourage you to be interactive and engaged and ask and clarify anything that you may need to do today. We're going to start out with a review from Natalie Baker with the Long-Term Care Strike Team on the recent COVID-19 vaccination survey results that some of you may have participated in. And then we'll move from there to talk a little bit about how you actually get or order the COVID vaccines. And that will be presented by Dina Tarver. Dina's with Alliant Health Solutions, and Dina holds her MBA and BSHCA and serves as the vaccine advisor with Alabama Alliant Health Solutions, and she's my colleague. And then finally, we'll have Elizabeth Subchat. She will talk about how to actually get reimbursed for the vaccine. Elizabeth serves as the Associate Executive Director and Project Director of the CDC Cooperative Agreement for AMDA, the Society for Post-Acute and Long-Term Care Medicine. She has worked on immunization implementation issues across the lifespan for the last 19 years. Her current cooperative agreement focuses on improving rates for both staff and residents in long-term care setting. And then at the end, we will do a final ask for Q&A. But as I stated earlier, we do encourage you to participate throughout and put any questions or comments in the chat or Q&A. So with that, I am going to turn the program over to Natalie Baker. Thank you.
Anyone who may not know me, I'm Natalie Baker, and I am the Infection Prevention Supervisor of the Long-Term Care Strike Team. And so I apologize if anyone attended the boot camp and has already seen these slides, but I very quickly wanted to kind of set the landscape for what's going on in the state of Alabama as far as COVID vaccinations. I know everyone is COVID vaccine fatigued. But unfortunately, COVID has not left our communities. So we still need to be on guard. So some of you may remember that I sent out a survey to all of the nursing homes in the state. And it was open from January 18th through the 26th. So this is about 6 weeks dated. But I feel like it still is a good data point for us. So we had a 60% response rate, which is phenomenal. And I want to thank anyone who is in the audience who participated, because we know how valuable your time is. And so when I referred to the new COVID-19 vaccine, I was referring to the one that was released back in September. And this was before we even knew that the CDC would be recommending a second vaccine, which has recently come out. So, erase that part from your memory. We're only talking about the new vaccine that came out in September. And so a large portion of you all said that, yes, that you were administering the COVID vaccine in your facility. So kudos to you. That was 86.6%. And at the time that I sent this, survey out, we had a national average of 38% of vaccinated long-term care nursing home residents. But in Alabama, we only had 28%. So I was surprised to see the number this high, but thank you so much. That's great. And so then I ask, if you are administering the vaccine, is it only being offered to residents, or are you also including staff? And now again, 76% of you guys said you were also offering it to staff. And that is excellent, because I know there's all kinds of caveats as far as being reimbursed if you're also including your staff. So if you were not administering the vaccine, I'll ask you about barriers. And so this number does not necessarily equal 100, because you could pick more than one. And so then we looked at, what were some of the common barriers? And so the most common were a lack of interest amongst the residents or families. 21% of you stated that you were having problems getting the vaccine, which is one reason why we have Dina here today. And I know that reimbursement also feeds into that. Some of you were having problems that you couldn't get the pharmacy support to come out and help you administer the vaccine, like we saw in the early days of the pandemic. Some other reasons that I thought were noteworthy were there was no time to give the vaccine. We know that you all are operating short-staffed. Residents and families were refusing the vaccine. Or you said, we did administer the vaccine, but both staff and residents usually go outside of the facility to get the vaccine. So then I've also asked, do you have any suggestions on overcoming the barriers to giving the vaccine? And we had some really rich information here. There was a lot of comments about a lack of confidence in the vaccine and safety. And we know that that is an ongoing concern. Again, lack of interest. We had people state that they really felt like there needed to be more education and awareness on the need for the vaccine. The cost, obviously, a factor. Given the vaccine, not having enough staff was another factor. And also just several people commented, the right to autonomy, and then people do have the right to refuse the vaccine. So I also announced at the boot camp that now the long-term care strike team, we can come back out again and give the vaccines. Some of you may recall that back when the federal government was supplying the vaccine, we were able to get the vaccine, bring it out, and do everything for you. We cannot actually order the vaccine for you or, get the reimbursement for you. But if you can get the vaccine, then all you need to do is contact the strike team, and we can send nurses out to actually give the vaccine. And we will also do all of the recording in imprint, which we all know the imprint's not the most software friendly user out there. So with that, I will turn off my screen, and Beth, I will turn it back over to you.
Thank you. Wonderful information. And I'm quite impressed with that rate of return on survey. Really, really good. Thank you for sharing. And so at this point, I'm going to turn it over to my colleague, Dina Tarver, and she's going to talk to us about actually ordering the vaccine. And Dina, I'll turn it over to you.
Hi there. I'm going to stay off video because I've been having connection issues, and it seems like if I stay off video, it helps to stay connected. So thank you for having me today. I do work with Beth. I am the vaccine advisor for Alliant Health, focusing on the COVID vaccine. This role is relatively new. We identified a barrier as we worked with many nursing homes with the 7 states that we represent. And one of the barriers that we were running into was access. So they developed this role in hopes that I could help come up with some solutions to getting the vaccine into the building for our nursing homes in this particular demographic. I have been able to meet with the big three, as I like to call them when I meet with them. So Pfizer, Moderna, and Novavax have all graciously met with me to talk to me about these barriers. Some of the manufacturers were not aware that we were experiencing these barriers with this demographic. So it was kind of an eye-opening revelation to them as well as we have talked. So some of the things that I have learned as I have talked with the different manufacturers is that our buildings, as we have talked to them, and they are not able to get the vaccines through their local pharmacies, be it that they're in rural environments. Sometimes pharmacies are backed up. All three of your manufacturers have direct ordering. So you can skip your pharmacies altogether. Now, when you do direct ordering, let's say you go through Pfizer and you want a direct order from them, that's who you're using, you would set up an account at primevaccinespfizer.com, and you would have a 2-box minimum where you could order from them. They do have a shelf life of 6 months in the refrigerator. This is a non-frozen formulation. The good thing about the ACIP recommendation for this demographic that we particularly work with 65 and over, them recommending that they get the additional dose, is all three manufacturers have told me that they do have ample supply to cover this additional dose. Moderna, you can order directly through them as well. The good thing about Moderna is a lot of our buildings don't have the freezer and refrigerator space to hold these vaccines, especially when they come in the fall with that flu vaccine. So Moderna can be frozen up to 9 months, which is what their shelf life is. They're good in the refrigerator for 30 days, and they only have a 1-box requirement. So ordering directly through some of these manufacturers is going to take away that large ordering requirement from you and allow you to order in smaller quantities so that you're not having to, write a big check for doses you potentially won't use. So the requirements are smaller as well. They did recognize that as an issue. Novavax does not have direct ordering at this time. They are working on that for next year. So for those that you cannot do a direct order from, like Moderna and Pfizer, you can also use your medical supply companies to order any of these vaccines. So if you use McKesson or whoever you order your medical supply company, who your medical supply company is, your doctor would just need to order the vaccines through that medical supply company for you as well. So that's just another workaround to the pharmacies that may be behind. Novavax is multi-dose this year. Next year, they will be single dose. So no more of the multi-dose pulling up vaccines in the buildings. It'll be better for you in the pocket and the money that we're having to put out for these vaccines. Theirs is in the fridge and it's never frozen. The other thing that I got from all three of the manufacturers, well, Novavax again excluded from this. Novavax is your alternative. It's the non-mRNA vaccine. So we do deal with the myths that are out there with these vaccines. A lot of times the younger population is concerned about DNA changes. That's a myth that's out there. Another myth is that it may affect fertility. So Novavax may be the alternative that you can educate any staff or people who have those kind of concerns, breaking those myths. But it is an alternative. It is a non-mRNA vaccine that can be ordered. The other two vaccines, Pfizer and Moderna, you can place your orders for next fall now. And that is what we would like to encourage, is for all of you, as you are ordering your flu vaccines, let's go ahead and get those COVID vaccines ordered now. The vaccine is not going anywhere. It is going to remain a recommendation, especially for this demographic. So starting to plan now for what you need for next year would be a great idea. Moderna is currently taking orders for the 24-25 year if you order directly through them. Pfizer has opened their pre-orders as well. What you need to do if you order through your pharmacy or through your company that supplies your medical supplies, is find out from them when you can pre-order. It should be opening up soon. So when you order flu, order COVID, and do those both together. That should take care of a lot of the access issues because they'll already have them in-house for you all. The last thing I'd like to mention too, because a lot of one barrier that we get is with billing. So billing comes up a lot. All three of these manufacturers have a program for reimbursement. So if you have vaccines in-house that you never use, if you open Novavax and you didn't use all of the doses that are in there, you didn't pull all 5 up and use those, they have a return policy, so you all can get credit back for those. So you just need to look on their sites, talk to your pharmacies if you order directly through them, to find out about kind of like their buyback program for you, so you're not losing money. But they all have reimbursement programs for you in place so that you are not losing money that way. And then the I'm not sure if you all have access to the AMDA billing guide. Moving Needles also wrote this document. This document will show all of you how you can bill that the vaccine is covered, even for your Part A stay residents if they are in their Part A. This document tells you exactly how to bill the pharmacies, how to bill, if they can bill, and then tells the buildings how to bill, when to use roster billings. It's a really nice document they've written for you to help you all with the billing issues that are out there. Any of you at any time can reach me at Alliant. You can just email me at dina.tarver@allianthealth.org, and I'll put that in the chat so that you can see that. With any vaccine questions, issues related to education to access, I'm happy to help you there.
Great. Thank you, Dina, for that most informative presentation. I just want to pause a minute to check with Wade. Do we have anything in Q&A? I don't see anything in chat that we need to mention.
We do have a question in Q&A, Beth, but I'll save it till after Elizabeth does hers because it is regarding reimbursement.
Okay.
So
Perfect. Thank you. And so, Dina, you just set up the segue beautifully to move right into Elizabeth's presentation around vaccine reimbursement. And with that, I'll turn it over to you, Elizabeth.
Thank you. It's great to be with you all today. I have a suddenly needy dog that you might meet in just a second here, so sorry about that.
That's okay.
So I work with a CDC-funded cooperative agreement on improving immunization rates. We had heard about all of the struggles related to billing, and so have just sort of put together some information. This doesn't solve the problems necessarily, but hopefully at least defines the pathways to get to reimbursement. And so I just wanted to start with a quick overview around the residents. There are 2 opportunities to bill or recoup costs that I think it's important that everybody knows about. The first is the product, the vaccine product itself, and that can be billed and paid for in the ways that we'll talk about in a minute. And then the second is its administration. You should be getting compensated for the time that you're spending doing the vaccine administration, and that's a separate fee. It's usually somewhere between $20 and $40, just depending on a number of things. But when you do that enough, it can certainly add up to help cover staff time to do that administration. So we want to make sure that you're billing both of those pieces separately. So to clarify a couple of pieces, the Part A residents have to be billed by the facility. For Part B vaccines, it's going to get complicated. We're going to dive into the weeds. You're going to have questions. It's okay. We're going to make it through together. So for the Part B vaccines, which are flu, pneumococcal, and COVID, if you have a Part A resident, those have to be billed by the facility itself, but you can bill both for the product and its administration. The long-term stay residents after their Part A stay can be billed by the facility or the pharmacy for those Part B vaccines. So flu, COVID, and pneumonia again, both PPSV 23 and PCV. And so then the last part is your Part D vaccines. The pharmacy has to bill for all Part D vaccines and their administration, regardless of stay. So that's just setting up this billing guide. You can find the exact link in the slides, which will be sent to you after the call today. You can also go to movingneedles.org and it's under our publications tab. It should be pretty easy to find. So just calling out where the pharmacy and the facility are in the billing process for each of these pieces. We start with the residents, and then we move to the Part B vaccines, and then the Part A stay residents. Again, the facility is the one that has to do that roster billing on a Part B claim. It is called out from your global billing and your bundling. And so it is reimbursable separate from your per diems and your global payments. The pharmacy cannot bill directly for those residents in their Part A stay. I know this was different during the public health emergency. We've talked with CMS about whether or not we could go back to those provisions where the pharmacy can bill for everyone. And as of 2 weeks ago, the person that I had talked to said he has talked with every lawyer at CMS that he can find, but it's built into the statute that the facilities have to bill for this particular group of folks. Different from then the long-term stay residents, where either the facility or the pharmacy can bill for both the vaccine cost and its administration. So now let's talk Part D. I know COVID is a huge focus for everybody, but there are a number of other vaccines that are out there and recommended for older adults, Tdap, shingles, and RSV in particular. I know a lot of folks have been asking about RSV vaccine. And so that falls under Medicare Part D, and the pharmacy has to bill for both the cost and the administration. But I think it's important to note that you can build in to your contracts with the pharmacies that they can reimburse you for that administration. They have to do the billing, but they can provide that back to you if you're the ones doing the actual administration. So that is a potential source of revenue for you to consider if you haven't already. There is just a quick note around exceptions and special circumstances when a vaccine such as Tdap is administered therapeutically for post-exposure prophylaxis instead of preventatively. It's included in the Part A global bundled payment for the Part A stay residents. I know that's a real nuance, but want to make sure that we at least call out that there is that single special circumstance. I'm not aware of where you would apply shingles or RSV therapeutically, but if there are those instances, then they would fall under the same exception. So that is the resident side. The staff side is certainly very challenging right now. I just want to acknowledge that. It's not ideal in any circumstance. So we've been trying to work through where some solutions might be. But the long-term care pharmacies generally are considered out of network for staff. They contract with Medicare. They don't contract with United, Aetna, Cignas of the world. And so typically what we're seeing happen, as you probably know, is that the facility will either end up eating the cost or having the staff pay, which is not particularly feasible for the more expensive vaccines. We have heard that Walgreens may come on site to administer COVID vaccines through the Bridge Access Program and some work that CDC is doing. They can bill for insured staff and uninsured staff in most circumstances, but they do have typically a minimum dose requirement or a $750 fee to come on site. So I know that's not always an ideal situation either. The minimum dose requirement, I think we've heard, is somewhere between 50 and 150 doses, depending on who you're talking to. And I know that's not incredibly feasible in most cases for most of these facilities. I think we've also seen that some third-party vaccinators can come on site and they can bill insurance. I think we've seen that as kind of the most feasible option at this point, but most are not part of the COVID Bridge Access Program. And so they may not be able to be a provider for the uninsured staff in that instance. And then the other option, which places an access barrier, but also gets it covered, is that staff can go offsite to a provider or pharmacy that's in network for them, and they can receive their vaccines there as usual. I think our goal would be to remove that barrier for them to be able to receive it on site, but I know there's a lot of billing challenges there, and we've heard that, and we are advocating with CMS and CDC around those challenges. And I think what we've seen in our own project is that there is very much a drop off in numbers, and I think that can be not all completely explained, but at least majority explained by staff not having access to that vaccine on site to be able to get it. So I just wanted to briefly mention, in addition to the billing guide, our project has a number of other resources that are available. We developed a staff in-service based on a survey that we did of frontline staff and what they said about what they want to know about vaccines in a professional development capacity. It can be 30 to 60 minutes. It has optional slides to tailor for your audience, and it's really meant to neutralize the conversation around vaccines. Talk about them as what the high risk is for staff, what the higher risk is for residents, and then provide some basic FAQ information. We also have a training. The staff told us they would like their supervisors to deliver that in service. And so we have a 10-minute training that they can go through to understand the survey results, why they are a trusted source, and to give them an overview of the content before they take that PowerPoint and deliver it as an in-service. We also have some technical documents around electronic health record and immunization information system interoperability. I know this is a really sort of much smaller group of folks who may be interested in this, but we've seen a lot of success with folks who are able to access their immunization information systems to get resident history. And so we really want to push towards better interoperability so that you don't have to dig through continuity of care documents, family history, and all of that to see what residents have had in the past. We have a newsletter, quarterly newsletter that you're welcome to join to get a one-page sheet of information about the project. And then we have some posters and fact sheets if you're interested in that. We have, for example, tracking your rates that can be, we actually have a couple extras we could ship you if you're interested, but they're laminated and you can track with dry erase markers where your rates are so that people can see and have a common goal, both for residents and staff. And all of those are up on our movingneedles.org website. We're working towards a change package that has some very specific strategies that folks can implement to see those rates improve. Standard operating procedures have been our best boost so far, but we recognize there are some other hesitancy challenges to address. So we're working on that too. So I'm happy to answer any questions and see if there's anything else we can do to be helpful to you guys as you try to get paid for the work that you're doing.
Thank you, Elizabeth. Another excellent presentation. And learning for me from both you and Dina. I have put a comment in chat. We encourage you to take this opportunity to ask questions or share comments, you know, things you've heard that maybe you want to be sure, is that accurate, not accurate? While we have these subject matter experts on the line with us, and we still do have time. We don't want to keep you just to keep you, but we certainly do have the time allotted to ask, answer any questions and collaborate around any comments that you might have, and as well for our strike team or Nursing Home Association, if there's anything you would like to share as a result of these presentations, we invite you to do that as well.
And Beth, we did have a comment in Q&A that come across as my understanding is the vaccine is not paid for by the government now, is very expensive and is not covered by, or at least not completely covered by insurance. Our company no longer offers due to the cost and it not being covered.
Yeah, hopefully some of what I just shared helps clarify where those places are. If you do have places where the vaccine, where you're not getting paid for the cost of the vaccine itself, please reach out. I'll put my email in the chat. We'd love to know about those places where they're not covering the full cost of what you're purchasing it for, so that we can do some advocacy with the companies and CMS as well.
And I know we certainly appreciate your advocacy. And I have, Elizabeth, in the past, reviewed some of the resources you shared, and you guys really do have some really good resources and flyers and that sort of thing.
Thanks.
Yes.
We're trying to keep it real practical. We know you don't have a lot of time and energy in the day, so we want to make it realistic for you to be able to take these and use them in a way that solves your problem, not adds to it.
It's a great point. Great point.
Yeah, and if I could also just put a plug in for the work that Elizabeth is doing. You know, AMDA is an extremely large national professional organization, and you know they're one of the giants in our field, and they are very connected with health policy, very connected on the Hill. Unfortunately, no one seems to have the power to go back to, you know, the federal government paying for these vaccines. You know, those days are gone. But Elizabeth and her team, they're working very hard to try to at least find solutions and to try to educate. We also know that there is still that somewhat mistrust in the federal government, not understanding, well, why do we continue to have to take additional, COVID vaccines? And, I can somewhat answer that, and just to remind everyone that, COVID is a virus and viruses mutate. That's what they do. Think of them as the flu. Every year when we get a new flu vaccine, it's always a different formulation. So throughout the years, we've become very accustomed to taking a flu vaccine every year. That's just part of our culture. And unfortunately, now we have COVID, which is most likely going to parallel what we do with the flu, and most likely, ever so often. I don't know if it will be annual, we don't know yet, but there will be new formulations for the vaccine. So for not trying to get political at all, but just as a matter of fact, our patient population is very much at risk for increased severity of symptoms and mortality. While we know right now the variants for COVID don't seem to make people very sick, unfortunately for our patient population, it can be the difference between, requiring hospitalization or unfortunately death. So that's why there's still a focus on the long-term care residents. And I know that the President Biden's administration has made this one of their priorities to get vaccination rates up. Hence another reason why we wanted to bring this to you guys today.
And Natalie, just to add on, this is Dina. Yeah, all three manufacturers pretty much confirmed that it's going to change. It's going to be a new vaccine for next year. They do know that. It's not been approved yet. And on another note, as you've talked about the flu vaccine is going back to a trivalent mix. So that is, the quadrivalent we've been giving for so long, now it's going to go back to trivalent. So it's just another example of how things are constantly changing with these viruses, like she just said. And the COVID vaccine may change every year. We may get to where it's stable and it's the same, just like the quadrivalent for the flu was the same for so many years, but it will be changing as well.
Another thing just to bear in mind with the older adult population, their immune system is not as robust as younger adults. And so that is why the CDC, I think it was last week, possibly the week before, they came out with a recommendation that older adults should get a second dose. And most of what I'm reading is a 4-month interval between the first dose and the second. So for those of you who, have been very vigilant in getting your residents vaccinated with the new formulation, it's time to start all over again. And again, we know that's very tiring, takes a lot of your time, but we just need to, again, remember we're there to help protect them and keep them as healthy as possible. That also translates into the employees, the staff also being vaccinated to be able to protect the residents that they're taking care of. And Dina, I had a question. You mentioned that for, some of the manufacturers, a minimum order was like maybe 1 box or 2 boxes. Can you give us an idea of how many doses is in each box?
Yes, ma'am. So if you ordered from Pfizer, a 2-box minimum is required. There are 10 doses in each box. That would be 20. For Moderna, it's a 1-box order requirement directly, and that is 10. And for Novavax, it is a 2-box order, comes in 2. There's 5 in each because it's a multi-dose. That's just for the remainder of this year, as they're going to single dose next year. And that would be 1 box would be 10. Right now with the multi-dose, it's still 10. So there's 5 in each vial.
Good question. Good clarification on that. I was trying to type too as Dina was talking, so I missed a little bit of that. So thank you. I did also want to just add, I know that there's a number of facilities that, in all states, but we're just talking about Alabama today, that are being, outreach to regarding a 0% up to date. And I wanted to thank you, Natalie, and I think as well, Elizabeth, for kind of clarifying what that means. Like, when does up to date officially start? You know, like back in the fall, that the slide you shared, because I know that I personally have received that question, and I know some other folks in our team have received that question, and there's been some confusion around, you know, what is officially now up to date considered. So I don't know right off the top of my head, Dina, not that it really matters, but you if you've received those calls from Reliant, we are around a 0% up to date. We really do want to try to help you through the avenues that have been discussed today. Because access problems, as Dina said, has been mentioned, and cost has been mentioned. And so hopefully you've gotten some information today that will help you move forward. Again, we know it's resident choice. We know it's staff choice. The biggest thing that we want to be sure of is that you at least have all the resources that you need to move past other barriers that are expressed.
Hey, Beth, we had another comment and question in Q&A.
Great.
And it states, out of several recent cases of COVID-19 in my facility, the two were the sickest were vaccinated 3 weeks prior with the 23-24 updated vaccine. The few others who had COVID around the same time, including one who is 94 years old, recovered in just a few days after minimal illness. How am I supposed to convince employees that they should consider the vaccine after seeing how bad sick these two were?
Who wants to take a stab at that one?
I don't mind starting, and then maybe Elizabeth might have something to add. I validate what you are saying. I would remind people that everyone reacts differently, and it typically takes at least 3 weeks to mount a response from a vaccine. So, you know, not knowing if those two residents had actually mounted their response yet to the vaccine, or it could be that they were exposed at a window of time when their immune system was lower and therefore they were sicker. I don't know. But you're right. It is hard when you see situations like that, then to still try to encourage people to get the vaccine.
I agree with you, Natalie. I think it is challenging, and the messaging around COVID vaccine has been really challenging. In addition to the points you made about when immunity fully starts after having received the vaccine, I think the other piece is that we don't know if those residents without the vaccine would have been even worse. So there's always the possibility that they could have been the ones that passed without the vaccine. It's so hard to message and say that because we just don't know what their reaction would have been. There are some folks that seem to get COVID quite badly, and we can't predict right now who those people are. And so that vaccine may have been helpful to those two individuals who got so sick. So I think it's absolutely challenging. Hopefully the points that Natalie and I made help communicate some of that. I think it's important to reiterate that it's not the vaccine that's making it worse. It's these other pieces that we don't know about. Potentially the vaccine could have made it better, but it will still prevent hospitalization. It will still prevent death. Which I know is a hard sell for the staff who don't think that those are going to be issues for them anymore. So I appreciate the challenge that you have ahead of you.
Thank you. Wade, do we have other questions in the Q&A?
No, ma'am, not at this time.
So we have about 2 minutes left. And again, we encourage you to put any questions or comments in chat or the Q&A. And also just want to encourage you to reach out to the folks on the call today. Dina, Elizabeth, of course, Natalie and Wade, part of the family, you know, Leanne, and utilize those resources, you know, don't stumble. And I think Elizabeth said it really well, to appreciate the challenges that you have, because there is certainly an appreciation for what you deal with and what you hear day in and day out. And then the ask of you on top of that.
I might just add that I think what we saw in our survey is that that it's important to recognize that staff are very logical in the decisions that they're making. It's not just a situation of, you know, I'm hesitant, I'm against it, whatever. But they really do have a logical reasoning, you know, whether it's because they don't want to be out with side effects and they don't want to be out if they get sick. They'd rather just take the chance and get sick because they don't want to not get paid both times. Whether it's because they see somebody who got the vaccine and was very ill when they got sick still. And so I would just say that I think recognizing that staff are rational, logical people, and that you start with that and say, I understand your concern. It's a very reasonable concern to have, is a great place to just start conversation. Whether even sometimes whether you think it's reasonable or not, there are typically some very logical reasons behind it. And so at least starting from a place of respect for that logical reason is a great place to start the conversation and to sort of lay out the points, and let them, you know, come to those conclusions as you draw out those points.
That is an excellent point, Elizabeth. Thank you for sharing that, because I know here at Alliant, we've worked really hard with outside consultants on the whole behavioral science piece, and, you know, how to say the information correctly. And so thank you for sharing that. And I also see that Dina came off mute. So Dina, I didn't know if you had any final comments you wanted to share.
I was just going to kind of add to that person that had the concern about getting the vaccine and people still really got sick, even though they were vaccinated, that, you know, it's you got to look at their comorbidities. You have to look at if they had heart disease or COPD, because they're affected worse. And I think some of the victories that we need to take, because, you know, with vaccines, we're not going to prevent disease necessarily, but we're hoping to lessen the effects of the disease and decrease mortality. So sometimes those are our victories themselves, that those two that did become so sick recovered. And that's a victory, and that can be the victory. You know, hopefully we can credit that to the care I'm sure that they received in their home where they were, and also to the vaccine itself for this particular demographic.
Excellent comment, Dina. Thank you. Do we have anything in Q&A, Wade? Okay, no. Okay, well, I know we're 2 minutes over, but that's okay. This has been a great meeting. Especially want to thank Elizabeth and Dina for being with us today. We appreciate you and the resources and the value that you bring. I don't know if maybe Natalie or Wade can just real quickly remind folks how to get the recording and the information and the PowerPoints from today.
Yes, so those, once the recording's completed, we'll be able to email that out to participants from today, and then the recording will also be placed on our long-term care strike team webpage.
Perfect. Okay, well, thank you again for being with us today. Thanks for the great information shared, and stay tuned. Our next IP office hours will be, it's still to be decided, but we always share that information in the weekly roundup through the Alabama Nursing Home Association, and we certainly appreciate the sharing in the newsletter as well. Y'all have a great day and a great week. Thank you.